So, Anisocoria. Eyelid positions and extraocular motility must be evaluated when anisocoria is present. Classifications. 1. The abnormal pupil is constricted. Unilateral exposure to a miotic agent. Iritis, eye pain, redness, and anterior chamber cells and flare. Horner syndrome, mild ptosis on the side of the small pupil. Angrio-Robinson's pupil, always bilateral, irregular round miotic pupil, but a mild degree of anisocoria is often present. A long-standing AD's pupil, the pupil is initially dilated, but over time may constrict. Hypersensitive to pilocarpine. The abnormal pupil is dilated. Iris sphincter muscles damaged from the trauma. Torn pupillary margin or iris strand illumination defect seen on slit lamp examinations. AD's pupil. The pupil may be irregular, reacts minimally to light, and slowly and tonically to convergence. Hypersensitivity to pilocarpine. Workup. History. When was the anisocoria first noted? Associated symptoms or signs. Ocular trauma. Eye drops or ointments. Syphilis. Old photography. Old photographs. 2. Ocular examination. Try to determine which pupil is abnormal by comparing pupil sizes in light and in dark. Anisocoria greater in light suggests the abnormal pupil is the larger pupil. Anisocoria greater in dark suggests the abnormal pupil is the smaller pupil. Test the pupillary reactions to both light and near. Evaluate for the presence of a relative afferent pupillary defect. Look for ptosis, evaluate ocular motility, and examine the pupillary margin with a slit lamp. If the abnormal pupil is small, a diagnosis of Horner syndrome may be confirmed by a cocaine or a proclonidine. In the presence of ptosis and an unequivocal increase in anisocoria in dim illumination, cocaine and proclonidine testing may be unnecessary. If the abnormal pupil is large and there is no sphincter muscle damage or signs of third nerve palsy, the pupils are tested with 1 drop of pilocarpine. Within 10 to 15 minutes, an AD's pupil will constrict significantly more than the fellow pupil.